So we can introduce this last patient for today. We can share the slides. So this is case number 10 for this so interesting program as a Medstream. We always like to say thank you to the organizer for inviting us, for having us for this terrific project. Next. So this is quite a relatively young patient. He's a male, 68. Presentation with dyspnea. He has history of hypertension, dyslipidemia, diabetes, non-insulin requiring, but the main problem is the morbid obesity, and this is probably the reason why he's here with us. He also suffered from coronary artery disease. He has received a PCI in another hospital in 2018 and 2022. Unfortunately, I don't have these answers to show to you today. And also he have suffered from some episodes of paroxysmal AF, atrial fibrillation. And this is the reason why he was under anticoagulation. Next. So the ACG is normal on the sinus rim at 63. Blood test is quite normal with a little bit high urea and creatinine in borderline. The body mass index is 44, and the echo Doppler unveiled severe aortic stenosis with area of 0.9, with a gradient of 56 and 34, the same gradient which was measured recently here in the lab. He has a preserved left ventricular ejection fraction with 55 as a ejection fraction. He is not frailty. He has a not frailty, and he's not fertile for this procedure. Next. So as I told you, I don't have a good quality of imaging of his coronary, but we saw, and there is no restenosis of his coronary stent on the right and on the left side. Next. So this is the angio CT. The diameters are 26 and 29 with a perimeter of 87. With the area of the annulus of 602, with this sinus of Valsalva diameters of 34, 36, and 37. So it's a huge aorta with the big annulus 2. The coronary osseous height is close to 19 for the left and 20 for the right. So they are quite high. We have some annulus in below the left coronary cusp extending into the LVOT. This is something to be considered, especially for predilatation. We are not going to be too aggressive. Next. This is a tricuspid valve. We also have probably 90 degrees of calcification on the sinotubular junction, but where the diameter is about 26 in average. Next. So this is the valve, which is a tricuspid with a significant calcification on the 3 leaflets, and this is the reason why we have decided to pre-dilate this patient before. Next. This is the coronary height. For the left coronary ostium is 19, for the right is 20, and for the non-coronary cusp, the height is about 24. So this is important, this height, because we are going to try, and I will show you one slide, that to be with the valve below the sinotubular junction to prevent any kind of dislodgement or detachment of this calcium, which is there. Next. This is the aorta, and this is another important issue. There is not a significant calcification on the ascending aorta or in the aortic arc, but this quite significant angulated aorta. You see that the angulation of the annulus in relationship with the ventricle is close to the 60, almost in the borderline for the self-expandable valve, and this is one of the reasons why we have decided to go today with the balloon expandable valve. This is our implanter's view that we regularly use for almost all valves, even for balloon expandable. We did a case between the first case we were live and this case, also with the Sapien 3, and we also use cusp overlap view for the implantation. In this patient, it's gonna be on right 1 degree and caudal inclination of 15 degrees. Next. So this is the aorta, a quite straight femoral arteries with some calcification on the common femoral, iliac arteries and in the abdominal aorta. Next. So this is the femoral axis. We have chosen to go by the right. This is a huge artery. The common femoral artery is 7/9. We are going to use this expandable sheath from Edwards. For the valve 29, we had to use this 16 French. So we need a minimum of 6 millimeters for the femoral artery or the iliac artery, sorry. But in this case, we have a huge artery. This is not something to be worried about it. Next. This is the left side. It's also possibly side for access, but we have chosen, as usually, the right if it is possible. Next. So in summary, it's a very young patient, but a young patient with severe aortic and symptomatic aortic stenosis. And the team discussion where Dr. Fava was, they considered that, according with the surgeon, that he is not a good surgical candidate due to specifically a morbid obesity and this huge body mass index. So you might see him on the table. He's occupying all the table. And I will show you some difficulties related with that. Next. So our plan today is to implant the TAVI. I told you this is going to be a balloon expandable valve, especially due to the angulation. And the strategy is to go femoral access as always. In this case, we have chosen to predilate. We are going to use not a big balloon, please don't touch the lights. It's going to be a 20 millimeter balloon, probably. Next. So according to the area, I have already mentioned, we have measured 620. So for the sizing, for the Sapien 3, we have considered these possibilities. We have, of course, chosen the 29. And we have different options to go nominal. It's going to be 4% of oversizing. With 1 cc, it's going to be 7. And with 2 cc, it's going to be 10.6. So percent, sorry, it's not percent there. So we have chosen to go 2 cc more than nominal for this case. Next. So here, probably click. Perfect, thank you. So here is the valve when it's crimped. The height of the valve, of the length of the valve is 30, but after the full dilatation, it's gonna be 24, with probably 11 or 12 up the annulus, above the annulus, another 8 millimeters below the annulus or intra and below the annulus. Show me the next. So we have to probably manipulate the valve to go not too deep, but not too high, trying to not to touch this calcification on the sinotubular junction, which was shown before. So we have this central market, and the idea is to go probably 3 millimeters below, but if we see that the valve is touching the sinotubular junction, we can go probably 1 millimeter below just in case. Next. So let's go back to the real life. What we have already done. We have done the puncture on the left femoral, common femoral artery. So probably we can show you the angio also too. We have a venous access here, and we have a crossover with the over-thin wire as always. But probably for people who are not using, I would kindly recommend in these obese patients, because the puncture is very high. Here is the inguinal area, and here is where we are. So here we're probably 8 millimeters above. So he is a huge patient, and probably if we have bleeding, it's not that easy to see on the surface. So maybe we can have a retroperitoneal bleeding if we are not having a good control from inside, a good checking before leaving the room. We are, especially for, I would say, normal common femoral arteries, we're using only one ProGlide. We tie the ProGlide over the 6 French introducer set. If everything is almost okay, we decide to leave it with just one ProGlide or to use an additional, an additional angioseal. But in this case, taking into consideration all these things that I was referring before, we have discussed with Dr. Carlos, and we have decided to go with the 2 ProGlides. And then probably we close the first one under the 6 French sheath, and if everything is okay, we continue with the 2, but if we have important bleeding, we can consider to put an additional angioseal. Probably you say, why you are spending so much time? Because this is, in this kind of patient, probably vascular complication is one of the most important issues, although they are young and have a very almost normal arteries. So what we are going to do now is to move here, is to put the first ProGlide. Dr. Mucarcel have already done an evaluation of the echo. Maybe you can comment about if we have pericardial effusion that we always check in advance.
Yes. Hi, everyone. As Dr. Mendes said, we already done the echo, so there's no effusion and LV function is normal. So this is what we do usually, first an echo to see that no effusion is present.
So here, when we have a very long distance, it's important you don't have a kinking before entering to the artery. So move down, okay. You see, before having black flow, you see that I almost completely in. Mostrame again. So here I'm sure I am in. Go back. So I will open and retrieve it, rotate, and let's go with the first. And then we are deploy the second. But you know, it's amazing, but the distance was almost not enough to get into the artery due to this huge amount of adipose tissue we have here. So we will introduce again the wire to introduce the second ProGlide. Dr. Mucarcel, how is the ventricular function in this patient? And if the gradient is the gradient that we had before?
Okay, LV function is normal. Let me check just a second again.
No, it's okay. It's okay, because we check it before you arrive.
Okay,
and it's almost the same. It's just to comment.
Yes, we have 64 of peak gradient here, about 4 meters per second velocity.
Okay. Very difficult, very deep is what I am doing here. How difficult to retrieve now. Amazing. Oh, I have here. Okay. Now we are introducing an unplugged wire, and we are going with the self-expandable sheath. So we keep the wire into the package. So with this being in the package, we can rotate. Be careful. I went into some vertebral, lumbar arteries. So we are going to introduce a sheath and give me the punto de seda. So we are going to fix the sheath because this is too. Thank you, Carlos. Please hold it there. Because sometimes it's difficult. Show me. Mostrame. Okay. So Carlos is attaching the introducer with the sheath because they are not fixed. And sometimes you can damage the artery if you lose the position. Yeah. So now I'm gonna fix it. Give me in there. Yeah, thank you. So yeah, is there any comment or question? I heard something there. No, the patient is moving, please. I'm not doing anything. Okay. Give me the knife. Okay, leave it there. Security. Now we are going to cross the valve. We will try to go as usually with the pigtail. If we can't, we go with the regular way of using amplas, catheter, and straight wire. Preparar una recta y un amplas. Okay. So after I finish this case, if we finish on time, hopefully, I will spend some minutes to discuss or to comment the previous case that we did almost in a rush. So you see, not that easy to see due to the morbid obesity, such a huge thorax. So we tried like this for some minutes. We have time today. In most of the cases we can, or it's not the day. Give me some minutes. Why I can try this? Because I'm not doing any other movement, because this wire is not traumatic. You have to be in the center, try to get in contact with the commissural. But probably due to severe calcification and aortic angulation, this is not going to be the case today. But give me 1 minute more. I rotate, trying to be in the center line. Well, we are not lucky today. Prepare the amplatz catheter. Should be there. There. It's enough. Okay, oblicua derecha. Pero un poquito más oblicua. So now I have a shade wire there. I have the pigtail. Well, if you take the time, you are not rushing, usually you can cross. Probably in 80% of the cases, you don't have to exchange, you don't have danger to stick the ventricle wall with the straight wire. Give me some water. So now we are going to position in the contralateral pigtail. Give me uno grande. Yeah. Oh. Give me a second. Oops. Okay. Pull a little bit, Carlos. Okay. No. Some reason I have some difficulty here. Don't know. Okay. I am in. Probably it's too late in the afternoon. But here, something that is very easy for the audience to realize is how the angulation of the aortic. So the annulus is almost vertical. So I'm not going to here, to the non-coronary cusp. Now exactly in contact with the deepest part of the sinus. Let me check. This is the working projection. Okay, let's go to the working projection. This one, 15, no? Okay. No. There. Okay. Yeah.
Lo confío.
I think it's the position is okay. We have a lot of calcium there. It's, we can also share probably the monitor with the, excuse me, with the pressure. So you can see there that this is a very tight stenosis with almost 100 millimeters of gradient. Let's check the zeros, maybe something is wrong. So in case somebody thought that we could cross because it's not the tightest stenosis, just kidding you. Okay, flash there. Okay, let's check. Well, it's not 100, it's probably 90, something like this. Rich, could you share the screen of the monitor where we have the loop of the blood pressure? Please. Yeah, thank you. Okay, so we have configured wire here. As always, we try to reshape, especially for small ventricles, to make it smaller as I can. I will try to show you. Give me a white. It's perfect. Eso es. So here in the camera, you can see that we have downgraded. Now it's probably, this is my finger, 2 millimeters, 2 centimeters. And then one additional shape here, especially in this case for very angulated aorta. If I had to perform this case with a self-expandable valve, probably I'm gonna go with a extra stiff wire. But this is not the situation when we have a deflectable catheter. I think it's not necessary. I know that probably Dr. Gemal would say that he's going to use it also here. But we are still reluctant to use it in all the cases. We use tortuociliac, heavily angulated aorta, 34 valve, self-expandable valve, I mean. Let us please retrieve, leaving the wire as distally as you can. The other issue is we are going to base him from the wire. We will test during the predilatation. If we don't like it, we can introduce a pacing catheter into the right ventricle as usually. So let's go with the balloon. We have prepared a 20 millimeter balloon. So it's smaller than the sinotubular junction. And we can prepare the valve for crossing and then to valve implantation. Yeah, we are going to leave the catheter here. Give me a second. Thank you, Claudio. So we are going to put the needle here. Some water on below the skin. We have here local anesthesia. So it's not problem to put a needle here, and the patient is also under conscious sedation. So we have scratched the wire here to have a better contact and probably better stimulation. So let's put this here. Carlos is going to hold the syringe. And then we are going to paste in 180, 180 on. Yes. Let's go, Carlos. Okay. Enough. Okay. Yes. Stop. No, leave the pacing.
Oh,
Sí, sí.
yes.
Okay. Okay. It was not expected. Give me the pacemaker, please. Dame el marcapaso con balón. So we have to change the strategy. That's why we have
Dame
this
el introductor.
introducer. We are going to change
The introducer.
the introducer set. And we are going to put the pace. Ayúdale.
Fíjate eso.
Okay, this is quite unusual because it was an 18 millimeter balloon with a big annulus. We haven't touched too much. So to be honest, I didn't expect something like this. Give me the introducer. Okay. Okay. And we are reshape a little bit the pacing. Probably for those who are not familiar with the technique, you can observe that the balloon is still on place. To isolate the wire to facilitate the stimulation of the left ventricle. If you pull the balloon out, probably you might lose the stimulation, and you see that we have a perfect stimulation there, having the balloon isolating the wire. So let's go with this. Perfect. So now, let me be prepared just in case, because we have to exchange one from the other. We are going to do it as fast as we can. So probably I'm gonna wait a minute, Carlos. You there?
Yes.
Where is the flag? Let's go. But now we have his own rhythm. But anyway, we are prepared just in case. Could you stimulate, Claudio? Okay. Okay. Okay, leave it at 40. So there we have his own rhythm. Perfect. Okay, let's go back to the valve. Dame floro, Carlos. So if you are going to ask me for how long we will leave this wire in the right ventricle, no, don't move without. If no, we can lose the position. Give me the valve. Okay. So going back to my comment. So the idea here is such a huge pension is not going to be that easy. Please pone AP. Okay, to have the wire and the introducer in the same. Lo más panorámico que tengas. Okay. Let's see, now we have it. It's okay, it's okay, it's okay. No tires la guía. So we have to make a big effort to introduce the 29 as always. And resistant there, but it's going. Don't pull the wire. So valve is out. Everything is okay. E is ending up. So we are Unlock. Carlos is gonna push the wire. I'm gonna positioning the balloon into the valve until the mark. Okay, here is the mark. This is the mark. It's okay. Now we have to go to fine adjustment. We can go by Zoom now. Ojalá voy guía un poquito. Okay, there. Now we are going to introduce the balloon in. So it's so big, the patient, that the image we have is not that good. Please zoom, one more. Okay, so now I think we are okay. You agree?
Yes.
Yeah?
Yes.
Perfect. Let's go. Let me move this, mostrarme arriba. Okay, let's go to the working projection. Let me hold the wire myself. It's okay. ¿Tengo que retirar? Yeah. Patient is too long. So we are going to deflect the catheter for the aortic arc. We can zoom a little bit now. And we are almost in. Okay. We can wait there. We can reposition in the pigtail, which I think is twisted with the valve. And I will need the amplatz wire to go into the sinus. Sí, ponelo. Let's go to the sinus. It's not that easy with the valve there. So let me retrieve the valve a little bit. Let me go with the catheter there. So now they are not twisted. The pigtail is in the right position. And I have to go a little bit deeper with the valve. Will you zoom, Claudio? Okay. Probably there. I will retrieve the sheath. Unlock. And I'm going up. There. It's okay. Okay, Mariana? It's locked. Okay. Will you test? Okay, throw a little bit higher. Do you agree? But not too much. Let's go with Cine. Cine? We are in the middle of the pigtail with the mark, no? You are, do you want a little bit higher? Okay. Okay, probably there. Do you like it?
Yes.
Yes or no?
Yes.
Test? Okay, I will put here. Little bit higher. Okay, so pacing, 180.
180.
Test. Let's go, Carlos. Todo.
Está toda.
1, 2, 3, 4, 5, deflate. Okay. Okay, stop pacing. We have ventricular tachycardia. Let's reversion. please. Yeah. Bien separado. Dale. Okay. It's okay. That's it. Okay. Please. Not epinephrine. Patient is hypotensive. Yeah.
Perfect.
One bolus. Give me some here, Nora here for the central line.
No.
Central line there.
No.
Okay. He's recovering.
Sí. No.
Give me the Amplatz wire. Well, this is a very
Dame
unexpected situation again. But
adrenalina.
this is when the team is ready for everything. We have to be prepared for everything. Can happen at any moment. This is interventional cardiology. That's what we mean. So I think the position is okay. It's almost perfect because on the non-coronary cusp is probably at 3 and probably 4, 5 on the left. Diastolic is now, well, the patient is still hypotensive, but I think we don't have to post-dilate anymore because put AP view, AP.
Okay.
Dr. Murcastel is going to check because if we have a good outcome, I don't like to overstimulate again this patient.
So let's take a look. Just a second.
I still have the wire inside.
So LV function is
Okay.
It's normal. So we have good ejection fraction, no effusion at all.
Will you check the gradient and regurgitation?
Yes. Okay.
Yeah, give me a second. Claudio, could you download the pacemaker at 70? Yes, Dr. Andres has some questions. Yes. Well, I would say this is going to be high. We have commented in previous cases that according to our series, here, when the patient doesn't have any kind of conduction disturbances, the pacemaker rate for self-expandable valve is 2%. But when this patient have conduction disturbances, including the EF, this patient have 25% pacemaker rate. So probably this is going to be the patient in this range, probably 20, 25%. And especially after this blockage, because we have a complete AV block. And now is under his no, I think he has a Wenckebach. Maybe we can, okay, we can continue with the echo, and then I will show you the ACG.
So we have normal gradients. Gradients are 14 and 7.
Okay.
And so far, no leak at all.
Okay, so we can pull this delivery system out, and we can introduce the pigtail. We can do an angiography. We can measure the gradient, and then we can decide what to do. I will extract the delivery system. I will pull everything out. You see that on the fluoro, that what we try to do is not touch the sinotubular junction. The valve is exactly below. Empujala aquí a Silvia un poquito. Patient is so long that the wire is almost not enough. Soltar. Give me the picture. Oh, time is okay. You see the angulation of the valve following the annulus angulation. So for self-expandable, would have been challenging, especially if after pacing we have this BF, because to try again to reposition would have been long and probably dangerous. So at the end of the day, I think we were lucky to choose this valve.
Zeros.
I have some bleeding here in the set. So here we have the gradients. Let me go with zeros. Okay. So we will do, will you show perfect? You are sharing the monitor. We have a good notch that there. The diastolic is not that, probably not too high, but the curve is okay. The blood pressure is 100 now. Probably we still have to give some norepinephrine or something like this. We will do an ansio 25 probably because he's too big to see what is going on. And we can do a test. Yeah. I think, let me check again because, you know, he's hyperdynamic, so big. It's difficult to see, but this, I mean, it's exactly according with the Dr. Mukarcel's findings. No gradient, no regurgitation at all. I think the position is okay. Probably 1 millimeter deeper than I like it, but it's okay. So I think we are finished here. We can pull this pigtail out. So I will show you in the monitor how is the rhythm now. Let me show you. So you see the patient is under probably complete AV block with some rhythm, but with the complete AV block. So we have to wait. We don't have to rush to put the pacemaker right now, but it's probably a patient who might need it, even though it is a balloon expandable valve. But you know, the conduction disturbance appear after predilatation. So it's totally unexpected. So we will try to close the groin. First, we try to reintroduce the introducer set for pulling the sheath, but I will connect to pressure with this on the other one here. Sorry. Will you expand him? ¿Lo puedes expandir un poco? Porque probablemente. How do you see that on echo? Is a little bit dry or
ELV.
necesita llenado o no?
A ver, let me take a look again.
Give me. So remember that the sheet was attached to the skin. So we are going to pull it. We have some light here. The 6 French introducer set is here. So I will pull the sheet, introduce the 6 French, and then I tie the knot. But before I'm going to go contralateral, just in case.
No, LV looks right. No diastolic dysfunction. The feeling looks good.
So probably
RV normal. No effusion.
Okay. tenemos que, podemos darle un poco más de drogas que tenemos que revertir. Ok, es ok. Bueno, subirle un poquito, así le damos la prota. Give me here. So any other question, Andres? Yeah, please. Well, yes, we usually go without predilatation with the balloon expandable valves, but not in cases with extreme calcification. And this is the patient with severe angulation and very high calcification of the leaflets. So that's why we decided to predilate. But, you know, this is, yeah, I know, this is operator's discretion. You can do it or no. There is not exact rule. Comprime, Carlos. You're scared about this closure because yeah, I would say that the first thing to be answered here is how long we can wait for the to deploy the pacemaker. To be honest, I don't know. Probably until tomorrow. Well, you know, the suture was broken, probably because the depth. We are now using only one. With only one, we are almost okay. But for sure, we had to use the angioseal. Give me the angioseal 8. It's so deep. It is impossible to go to reach the artery. So probably we also have to exchange. Give me, Carlos, for the balloon. Give me a 9mm or 8mm balloon. So we are going contralateral, and we inflate the balloon there, and then we hold the groin for minutes. So here is the angioseal. Again, I had to go too deep to get bleeding there, almost pushing. Oh, sorry. Everything is difficult here in this groin. So now it seems to be better. We have some oozing. You see with the camera here on the groin, just some oozing. But I will check it and I will inflate the contralateral balloon for some minutes to get the perfect sealing. I like to emphasize there. Give me, Carlos, to check. Protamine is still undergoing. So the sealing is okay. So we can hold it, move it. Light. Oh, I have the light, sorry. You see that the small thing of give me the knife, is exactly below this, the skin. It's terrible. Oh. It disappears. It's incredible. Incredible. How big is this patient? So I will tighten all the knots and we'll cut it. Okay. Carlos is gonna hold the balloon. And we can hold the groin. Yeah, the blood pressure is 100. No, yeah, 96, pero podemos subir un poco más. So we still have 5 or 10 minutes. This case is done. We will hold the groin to get the perfect sealing. We will test once more to be sure that it's, we don't have any kind of bleeding. And then we will leave the wire in the right ventricle for pacing. And we will call our colleagues to keep this patient in mind and to decide probably tomorrow morning to put the pacemaker if this conduction disturbances does not disappear in the next 12 hours or something like this. If disappear completely, we can probably leave the pacemaker on the right ventricle for probably 12 hours more until the tomorrow afternoon. And then we can decide if we can pull it or no. But this is the patient that is not going to go home tomorrow for sure. It's a patient who should be here in the hospital at least 2 or 3 days, because something that can revert can appear again 1 or 2 days after the procedure. So although we have a valve in a correct position, although we have a balloon expandable valve, this is a patient that for safety cannot go home tomorrow for sure. So saying that, I would say that this patient is completely finished. And I would like to thank to everybody for having us. And let me give the last 3 or 4 minutes to comment we have done in the previous case, just in case that somebody was watching and we were rushing because of the time. So what we did in this case, which was, or who was, sorry, a young male, we implant an bifurcated EVAR device, endograph. So to treat the abdominal aortic aneurysm. And because this patient has dilated and very short iliac arteries, we have to adapt one strategy. In this patient, we decided to go with hypogastric embolization, going for contralateral. We deploy probably 8 or 10 coils, concerto coils, into the hypogastric artery. After that, we advance from here the iliac branch, which is a bifurcated iliac device, especially for dilated iliac arteries. I show you that we have a contralateral rail, so we can advance into the iliac artery because of this rail, because without this rail, it's absolutely impossible. You have observed during the maneuvers to enter this sheath into the proximal part of the iliac branch to catheterize the hypogastric, the right hypogastric here. We deployed there a stent graft 8 by 58 millimeters. So we have a iliac graft to the external iliac and the branch to the hypogastric. And then we introduce the bifurcated device with a short stump to my size, here to the right, and the long stump to the left. For the right side, there was a gap between, which is normal to have this gap, it's not a mistake. And then we had to put a connector between this stump and the external iliac bifurcated branch. Finally, we deployed the extension from the main body until the external iliac artery, so to complete the sealing of this patient. Sorry for being in a rush, but I think with this explanation, probably when you see the case on the website of Medstream, you can better understand in case you are not a vascular surgeon or radiologist or cardiologist like us doing these kind of cases. So after saying that, I wish you have the monitor there. We can do one last check to see what rim we have. This is a complete AV block with 3-to-1 escape. So let me, yeah, it's there on the yes, upper corner and in the lower corner on the right. You see here, this is 3-to-1. I connect very quickly because the patient is not tolerating too very well. So let's do a final angio to see here, which is completely sealed, sorry. And then we will use an additional angio seal to close the left common femoral artery. So perfect, this is perfect. So Rich, probably we are done. If we don't have any additional question, Andres? Yeah. Yeah. Yes, so the question is if we were satisfied with the result of this first case that we were commented. Of course, because we occluded the hypogastric, we have a perfect patency of the right internal iliac artery. We have a complete sealing on the proximal neck of the aneurysm. There was some porosity in the middle of the body, but the patient was still under full heparinization. So this is something that you don't have to care too much. After the full reversion of heparin and in a few hours, or probably the next day, is completely sealed, and we will see this on the CT scan, and we have to remember to share on the social media so you can compare how is the outcome during the follow-up. If we have a problem, of course, we can share also, because everybody, including us, can learn what is going on with this patient. Any additional one? Okay, no more questions, Rich. I think we are done here. I would like to thank everybody for hearing us, for the question, and for following us. So I would say bye-bye. See you next week.